Hello everyone. Today I'll be talking to you regarding fungal infection of the lungs, and I'll be covering all these relevant to my talk. First, and a very important topic. It is a VIP topic. This question about this topic is asked throughout the world, whichever exam you appear. Universal question is there. So, since it is very important, so we'll give a due weightage to this topic. So, this is pneumocystic giardiasis. Formerly, it was known as pneumocystic carinii, but now the new name has changed. It is giardiasis is the new name. Well, it is an opportunistic pulmonary organism. Well, this word needs more elaborate discussion. It means it is a opportunistic means this is there in the lungs, in the normal lungs to be more precise. But whenever he gets a chance, he does the attack and causes the disease. That is the meaning of opportunistic pulmonary organism. So, I told you it's commonly found in the lungs of the healthy person, and of course it is looking for a chance. And what is the chance? That chance is whenever immune system goes down. When the immunity goes down like HIV/AIDS, then in such cases it can do an attack and lead to all the problem. And it is a yeast-like fungus. That's why we are talking in the fungal disease of the lungs. But what is important, initially it was classified as a protozoa, but now they say no, it is not a protozoa, it is a fungus. Okay, and most children are believed to have been exposed to organism by the age of 3 to 4 years. That means it is so common throughout the world that every child in the whole world by the age of 3 to 4 years, that is just you can say preschool child age, they are already have been infected. So that means organism is in the lungs, and whenever immunity goes down, it will flare up and cause disease. So friends, as of now, the key word to be remembered here is number one, it is a opportunistic organism. It is a yeast-like fungus. There are only two keywords that you got to remember in this particular slide. As I told you, occurrences in the worldwide, and how we get this organism by inhalation route, right? And as I told you, this causes pneumocystic pneumonia in a immunocompressed or immunosuppressed patient, the point I mentioned in the previous slide. And now come the point to remember, it is a AIDS defining illness, and often it can lead to fatal pulmonary disease. It leads to a type of diffuse interstitial pneumonia about which I'll be talking to you in the coming slide. Now, what is the point, carry home message for you in this? Worldwide we discussed inhalation is the one keyword, and second, it is a AIDS defining illness. So there are only two keywords that you got to remember in this particular slide, inhalation and it's a AIDS defining illness is there. Third, diffuse interstitial pneumonia, it has a special meaning. What the meaning, which I'm going to discuss in the coming slides. Now let's talk about immunology. I mentioned to you in the previous slide that this can lead to opportunistic infection wherever immunity goes down. But what immune component, both cellular and humoral immunity are defective. Point to be noted, there are only, because it's not a common thing that both cellular and humoral immunity will go down. And once inhaled, why? The route of entry the body is by inhalation route. The trophic form of pneumocystic organism attached to the alveoli. So this is the alveoli. The trophic form will go and get attached to the alveolar wall, right? So this is the entry. So the key word is both cellular and humoral, and it get attached to the wall of the alveoli. The two keywords that you got to remember in this particular slide. Now, Once it has landed up in the alveolus, it get attached to the wall of alveoli, and immune deficiency is there. And now this uncontrolled replication, they will replicate. They will just multiply, right? So now we all know very well that normally any organism which enter the body are removed by the macrophages. They are removed by macrophages. But these patients, especially HIV patients who are without CD4 cell, I don't need to tell you that in HIV CD4 cell count goes down. So due to that, the macrophages, these organisms which are there in the alveoli, they are not eradicated because of immunodeficiency. So the key word is uncontrolled replication is the only key word in the absence of CD4 cell. So why they are replicating? CD4 cells are not there. The two keywords are uncontrolled and without CD4. Now, who are the person at risk? Of course, see, HIV patient, AIDS patient. But when, this is very, very important question. When the CD4 goes down below 200 per ml, and of course the patient is not taking pneumocystic carinae prophylaxis, if not taking, then they are very, very prone to. But there are two words. That means they are, the patient is prone to infection. First of all, CD4 cell count is usually, not always. Some patient can be infected when the CD4 cell count is about 200 also, but usually is below 200. And the patient is not taking prophylaxis. It means what? We have a patient of HIV to whom you are doing close follow-up by CD4 cell count. The moment CD4 cell count come to 200, you should start prophylaxis, pneumocystic prophylaxis. Otherwise, he is bound to develop pneumocystic pneumonia. So there are two keywords here, prophylaxis and below 200. Patient receiving any immunosuppressive therapy, especially after transplant, any organ transplant. Children with primary immune deficiency disease, definitely I told you, any immune deficiency with patient are prone to pneumocystis. Malnourished people, they are usually immunosuppressed, and COPD. Chronic obstructive pulmonary disease is the patient are prone to this disease. What are the clinical features? There is a history of 2 to 3 weeks. That is a short history, not a very long history. Dry cough, fever with dry cough. Why dry cough? Because primarily it tends to involve the interstitium. Disproportionate breathless, this is the single most important feature. Patient is very breathless as compared to the symptom. So disproportionate breathlessness is the key word. So friend, the keyword are dry fever with dry cough and disproportionate breathlessness, the two keywords that you got to remember in this particular slide. There are very few signs on auscultation. The reason it is the interstitial which is primarily involved in this. No response to standard therapy. Patient manifests as pneumonia. You give standard drugs. Standard drug, point to be noted. This is again a very, very important. This need elaboration. What is that? Usually when we see any pneumonia, any guidelines, nice guidelines, what they say that when we that to treat a case of any pneumonia, we can give macrolides like azithromycin, or we can give drug like quinolones like levofloxacin, or we can even give ampicillin also. So they are the usual drug that we give. So these we are giving, maybe macrolide, maybe azithromycin, levoflox, we are giving, and they are not responding. Then again, that should an immunocompromised patient, if this is happening, then you should always think about pneumocystic. Exercise related desaturation, very fast desaturation. even on doing little exercise, and patient may have pneumothorax. So in this slide 1, 2 and 3, there are 3 keywords that you got to remember. Patient not responding to standard antibiotic. Of course, we soon will learn that in this case we gave cotrimoxazole, that is trimethoprim, and sulfamethoxazole is the drug, and that is not a standard drug to treat a case of pneumonia. So 3 keywords: no response to standard antibiotic, exercise-related desaturation, and pneumothorax. How we diagnose? Bilateral ground glass appearance. You can see typical ground glass appearance because it tend to involve more of the interstitium. Okay. Now you do ABG, arterial blood gas analysis. In type 1 respiratory failure, in type 1 respiratory we know there is hypoxia, hypocarbia. Okay, so in one more thing, PaO2 is slightly lower than expected symptoms. Symptoms are minimum. Patient will not have much of the cough. Of course, breathless will be there, but PaO2 will be very, very low, even out of proportion to breathlessness also. Okay, so minimum cough, more breathless, and much more hypoxia. So hypoxia is out of proportion to symptom. LDH is always increased. If LDH not raised, this is not pneumocystic cariniae. Such an important point that you got to know. It's a ruled out technique. No LDH raised, this is not pneumonia. This is not pneumocystis. So friends, the 2 keywords are type 1 respiratory failure and it is LDH is always increased. There are 2 keywords in this particular slide. Sputum examination is always very important, and we don't take routine sputum sample, what we ask the patient to get. It should be obtained by induction, point to be noted, by hypertonic saline. We induce to get sputum. Why? It's an interstitial type of pneumonia and there's no much of sputum, so we have to induce by hypertonic saline. And as I told you, routine sample are inadequate. The only one keyword to remember is sputum examination induced by hypertonic saline. Only one keyword. Now look into this. Methamine silver staining has been used. You can see folded cyst. You can see these are the cysts, folded. Cysts are seen. And maybe a comma shape also. So we are getting cysts, but we stain what we are using is methamine silver staining. So in this slide you got to know that, remember the name of stain and folded cyst. The 2 keywords, methamine silver staining and folded cyst, the 2 things to remember in this slide. Well, we have used silver staining in this. Let me give you a little bit more about the microbiology. Silver stain we have used. So where else we use silver stain? Silver stain we use in pneumocystic, I just mentioned to you. Silver stain we also use in coccidioidomycosis, that is fungi, Legionella and Helicobacter pylori. So this is extra knowledge, additional knowledge that where else we use silver stain, right? Fungi, Legionella and Helicobacter pylori. Now, bronchoalveolar lavage, BAL, it forms the mainstay of diagnosis. That is the most accurate test. Well, it's again, we are taking aspiration, but remember when we have done the saline induced, so we may or may not get any finding. But this is the most accurate test. Once we have taken the sample, we have taken the aspiration via bronchoscopy, then we can use silver stain. I mentioned in the previous slide also. But is the only stain? No, we can also use toluidine blue. We can even use periodic shift stain. So now there are 3 stains that we can use, but of course most commonly used stain is silver stain, but other stains are there, and they will show the characteristic cyst. What cyst? They are folded cyst. They may be comma shaped cyst can be there. So friend, the key word to remember is most accurate test is bronchoalveolar lavage. Only one keyword in this slide. Now look into this. Okay, there we have used stain, and you can see cyst we see, and there are internal nuclei of cyst up to 8 in number. You can see there are multiple stains are there, multiple nuclei are there in the cyst. The multi-nucleate cyst is the thing that you got to remember in the microbiology. Now lung biopsy. Okay, thickened alveolar septa with fluffy eosinophilic exudate in the alveoli. This is important. The alveoli contain lot of exudate. What is that? Look into this. Yeah. So this is the alveolus, and you can see so much of the material is there. Proteinous exudate is there in the alveolus. Okay. So definitely when the alveoli are full of exudate, so that will hamper the gas exchange. Gas exchange will lead to what? Severe hypoxia. So in the pathology, it is the alveoli which are full of protein content. That's the answer. Okay. And thickening of septa will happen with eosinophilic exudate in the alveoli. Is a pathological finding that you got in biopsy. Well, in some cases we can use, even in case of doubt, we can use polymerase chain reaction also. But in some cases, not in all the cases. Gallium-67 scan is abnormal. This is one thing not known to most of the students. It demonstrates increased diffuse system symmetrical pulmonary uptake in the lungs with pneumocystic pneumonia. Sensitive, highly sensitive, 100%. You can see that they are being taken up nicely by the lungs tissues. 100% sensitivity, near 100%. Okay, so gallium scan again we do only in case of doubt, where we are not getting any yield in ball or any other way, then we use this investigation. How we treat a case? Mild to moderate cases or severe cases. What we use? Dimethoprim sulfamethoxazole. Severe? Oh, same. What a nice correlation. That means first line treatment is always TMP SMX. TMP stands for trimethoprim. SMX is sulfamethoxazole. Whether it is mild, moderate or severe, treatment remains the same. Then second choice, if not, we can use dimethoprim plus minus dapsone or clindamycin plus minus primaquine. This you will use only patient is allergic to sulfa component. We know very well in TMX, TPM, SMX, this is the sulfa component. And there are many patients who are allergic to sulfa. In such cases, we'll be using either dimethoprim plus minus dapsone or clindamycin or primaquine, or third option is atovaquone. Again, in second choice is pentamidine or clindamycin or primaquine, or even we have trimethoxate is the other thing that is a choice, but normally we don't come up to that level. These are good enough to take care of these patients. By and large, single most important is trimethoprim sulfamethoxazole. It is given for about 21 days. Now, is the role of any steroids? Yes. Steroids are added to reduce mortality in pneumocystic carinae. Criteria you will use when the PaO2 is below 70 millimeter of mercury. Point to be noted, we say hypoxia when PaO2 is less than 60. We call as hypoxia. So a normal PaO2 is above 94 millimeter mercury. So when it has come to 70 millimeter mercury, we should start using steroid. We don't wait up to 60 to come. Or PaO2, that is, this is the alveolus. This is the arteriole. Here in the alveolus, we have a pressure of oxygen PaO2. And in the arteriole, we have pressure of PaO2. If this gradient is more than 35 millimeter of mercury, that is again an indication of using steroid. That again indicates severe type 1 respiratory failure. Got it? So there are two reasons why we have to use steroid. So in a routine case, we don't add, but once we find here going to hypoxia, then we add steroids. Now, indication for prophylaxis. I mentioned in the very beginning that prophylaxis, but when will you give? We give when the CD4 cell count goes to below 200 or CD4 cell count is less than 20%. This is so-called primary prophylaxis. Patient is a case of HIV. Patient is a case of HIV. And CD4 cell count below 200, we give, although he has not developed pneumocystis, but we start so that he doesn't develop pneumocystis. This is known as primary prophylaxis. Patient having oropharyngeal candidiasis, that means HIV patient has developed oropharyngeal candidiasis, start prophylaxis. This is again a case of primary prophylaxis. But now we have a term called secondary prophylaxis, so-called maintenance therapy, as given by the NICE guidelines or CDC guidelines. Now, what is this secondary prophylaxis meant by? It consists of therapy given to prevent relapse of known and appropriately treated any opportunistic infection. That means you got one patient on pneumocystic, well proven, you treat by giving trimethoprim sulfamethoxazole for 21 days. But we want to give a maintenance dose so that he doesn't relapse, and this is so-called secondary prophylaxis, right? So secondary prophylaxis is, so the new name is maintenance therapy. This is a new name, maintenance therapy. So we will give, if he was there, already had a pneumocystic and you continue with the drug, that is secondary prophylaxis. Who else should we give prophylaxis? Children born to HIV positive mother. They should be given prophylaxis by same trimethoprim sulfamethoxazole. At the age of 4 to 6 weeks only you start prophylactic drug. But you are giving prophylaxis to a HIV patient whose CD4 cell count is below 200. But the now count has come back to more than 200. For 3 consecutive months, for 3 months, CD4 cell count is more than 200. You stop prophylaxis. Okay? But his HIV drug, HAR, highly active antiretroviral drug therapy, it will continue. You keep on giving HAART, but you can stop prophylaxis if the CD4 count cell has gone to more than 200. It should be restarted if CD4 cell count goes to below 200. Very interesting. It was below 200, we gave. It came to more than 200, we stopped. Again, he come back to below 200, we give. That means the count below 200, you give prophylaxis. Okay. Now, the prophylaxis should be continued for life. Who developed PCP when the CD4 cell count was about 200? Very, very important line. Again, I mentioned in the previous slides that usually this pneumonia develops when CD4 cell count is below 200. But sometimes uncommonly they may even declare that pneumocystic when the count is more than 200. In such cases, you treat the patient, but you continue for the whole life giving trimethoprim sulfamethoxazole as a prophylaxis, because that is a dangerous. He caught the infection in CD4 cell count more than 200. So prophylaxis summary, CD4 cell count below 200, we give sulfamethoxazole. This is for pneumocystic. Below 100, we again give trimethoprim, but now it will cover toxoplasmosis also. Point to be noted. So for toxoplasmosis also we use trimethoprim, but we use when it is below 100. Below 200 is only it. That of course we are giving trimethoprim, but that will cover pneumocystis. Below 50, we give azithromycin or cletho as a prophylactic drug for Mycobacterium avium complex. That is again one infection common in HIV patient, but that occurs when the count is below 50. So these are some of the prophylaxis. This is extra knowledge for you, so that three important organisms for which give prophylaxis is pneumocystis. The key word is pneumocystis, toxoplasma, and Mycobacterium avium complex. So you should know they are the three important organisms which give prophylaxis. The drug is trimethoprim, and macrolide, azithro, and cletho are the prophylactic drugs. A quick recap of the last minute different point regarding pneumocystic giardia. It is an opportunistic infection. They occur when there is deficiency of both cellular and humoral deficiency, and there is disproportionate breathlessness is there. Best initial test is chest X-ray, where we get ground glass appearance. LDH is always increased. Bronchoalveolar lavage is the mainstay of treatment, is the most accurate test, and treatment is trimethoprim sulfamethoxazole. ABPA, that is infection caused by Aspergillus fumigatus. So before I talk about ABPA, let me discuss the basic concept about microbiology and mycology. Since it's a fungus, so we can say mycology. It's a septate hyphae that branch at 45-degree acute angle like this. 45-degree. They produce conidia in radiating chain. At the end of conidophore, I'll show you the picture just now. And it can lead to a type of invasive aspergillosis. That means it can lead to invasive fungal infection. In who are a patient? Again, immunocompromised, or those who have a chronic granulomatous disease. This is very, very important. Cannot afford to forget this line. Even more important than immunocompromise. Pneumocystic occurs in COPD also, but very important to talk about HIV. Here it is HIV also, but more important to talk about chronic granulomatous disease. Why? I'll be discussing in a minute only. The keyword are, it can lead to, the first keyword is invasive aspergillosis, and it is and the risk factor is a chronic granulomatous disease. There are only two keywords to be remembered in this particular slide. It can also lead to aspergilloma. Again, a very, very important point. Who? Pre-existing lung cavities. Patient has a cavity, maybe due to tuberculosis. The patient has a tuberculosis, he was treated with TB, he became alright, but during tuberculosis the patient developed a cavity. Now this goes and develop a ball, so-called fungal ball, also called aspergilloma. The key word is pre-existing lung cavities, especially in old tuberculosis. Now one more important point, some species of aspergillus, they also secrete aflatoxin, which can lead to hepatocellular carcinoma. So friend, in this particular slide, as for aspergilloma, Lung cavity tuberculosis, 2 words. And for aflatoxin, it can lead to hepatocellular carcinoma. In total, there are 3 keywords to be remembered in this particular slide. Now we talk about the topic ABPA. Till now we learned about basic. So allergic bronchopulmonary aspergillosis. It is what we call as ABPA, allergic bronchopulmonary aspergillosis. It is a hypersensitivity response, and that will lead to asthma and cystic fibrosis. Point to be noted. In a routine asthma, there is only, in a routine case of allergic asthma to be more precise, they have a bronchoconstriction. But here, bronchoconstriction manifesting as asthma. In addition to that, cystic fibrosis is a feature. And due to this, it can lead to bronchiectasis. And due to, it can lead to eosinophilia also. So the keywords are number 1, asthma, cystic fibrosis, bronchiectasis, and eosinophilia. There are 4 keywords that you got to remember in this particular slide. Now I show you. So we can see they are dividing. You can see these are dividing. Look into this. They are dividing like this. You can make out they are dividing narrow angle below 45 degree. You can see much better now. Yeah, you can see. So they are dividing below 45 degree angle. They are branching septate hyphae. You can see like this. Something. Septate hyphae are there. Okay. And branching at 45 degrees. Got it? Yeah. We are using methamine silver stain, and we are getting fruiting bodies. Look, you can see here. I'll be showing you one more picture. This is the beautiful fruiting bodies. They are all having spore, but I told you spores are made. This is the typical picture that you will get it. Now, biochemical reaction is very important question from microbiology or mycology. It is a catalase positive organism. Don't forget this. Very, very important, and this question is there in all the exam wherever they talk about basic sciences, whichever exam you write. So now what happened? Normally this catalase, this degrade H2O2 into H2O and oxygen. Okay, right? Before it can be converted to microbial product by the enzyme myeloperoxidase. So patient with chronic granulomatous diseases where they have deficiency of NADPH oxidase deficiency is there, and these patients are prone to catalase positive organism. So friends, in chronic granulomatous disease, which I mentioned to you, patients are prone to this because they are NADPH oxidase deficient, and any organism where NADPH oxidase is deficient, they are prone to infection by catalase positive organism. Now, what are the example? Again, more topic about microbiology or mycology, basic sciences. Which are the organisms which are catalase or positive organism? Not possible to remember all these names. The catalase positive organism, the mnemonic is cats need places to belch their hair balls. Oh, what is this? N for Neisseria, nocardia. P. Pseudomonas. L. Listeria. A. Aspergillus, the topic of the discussion just now. C. Candida. E. coli, Staphylococci, Serratia, then B. Sepacian, H. pylori. These are all catalase positive organisms. So you can write down or you can take a picture, whatever you want. The mnemonic is cats need places to belch their hairballs. First you note down the mnemonic. And now you can note down the list if somebody has missed anything. Immunology, as I mentioned in the very beginning, that it's a type of hypersensitivity reaction. What type? Type 1 and type 3, both are there. Both are involved. And they have a hypersensitivity to Aspergillus fumigatus. So-called fungal antigen, which colonizes the bronchial tree. Definitely, I told you they are going to colonize the bronchial tree. IgE level are increased and eosinophilia occurs. They are all the part of so-called immunology. Pathology. It leads to bronchoconstriction. That's why I told you they manifest with bronchial asthma. So, in asthma, recurrent attack of inflammation occurs. And other inflammation may persist for a long time, and that can lead to permanent damage, and that can lead to proximal bronchiectasis. I think this word is among the most commonly asked question. So it leads to proximal bronchiectasis. The usual option will be distal bronchiectasis. No, that's wrong. It's proximal bronchiectasis, and it is this element which the cause of recurrent hemoptysis. The patient can develop recurrent hemoptysis again due to proximal bronchiectasis. And intense inflammation of airway and mucus plug in the terminal bronchial, they contribute to the problem. Because mucus plugs are formed, they block the airways and they contribute to proximal bronchiectasis. Now, repeated attacks occur, they lead to necrotizing bronchopneumonias. Later on, it can lead to bronchiectasis. It can even lead to interstitial lung disease. And it may involve the vessel, which can lead to hemorrhagic infarction. Point to be noted, it can damage the lungs in various ways. Bronchopneumonia, bronchiectasis, interstitial disease, as well as hemorrhagic infarction. So it can lead to various pathologies depending on for how long the disease is there. Symptom wheeze. Why? Why wheeze? Because of bronchoconstriction. Cough. Airway is involved. Sputum. Plugs of when the patient has sputum, they contain plugs containing fungal hyphae. Dyspnea, recurrent pneumonia are the feature, and the one word they use is recurrent, fleeting chest abnormalities. Recurrent fleeting chest opacities we see in these patients. While this is very important. Why? It is this point which makes a differential diagnosis for Wegener's granulomatosis. In Wegener also there is recurrent pneumonia, fleeting opacities are there. In Wegener also hemoptysis occur. Hemoptysis can occur in ABPA also. So there are certain features regarding lungs, but in Wegener's patient also have involvement of upper respiratory tract, which is not involved in ABPA. In Wegener there is involvement of kidney also, which is not occurring in ABPA. Now so far I was talking to you regarding aspergillus causing lung infection. But Candida and aspergillus, they can lead to fungal endocarditis also. Point to be noted. Now the lesion has come to the endocardium. Of course, in endocarditis mainly by Candida, but even aspergillus can lead to. Now, what are the predisposing factors which can lead to fungal type of endocarditis? Long-term indwelling IV catheter. This is important. So quite common that patient has been hospitalized for any illness. It has been a long stay, and in due course of time, the patient develops endocarditis. It is a custom that this IV catheter, like suppose this is the catheter, needle. Like this. It is there. So they take out this and they cut it, this part. Tip is sent for the culture. Because it is this tip which contain, and that culture is for fungus also. Classical, that fungus culture should be done for this. This applied. So these endocarditis is common in malignancy, HIV, organ transplant and IV drug abuse. So now in nutshell what we find, any long-standing IV abuse or IV cannula or any condition which lead to immunosuppression. We are well aware that Candida infection are very common in immunosuppressed patient. So but aspergillus can also be there. Aspergilloma, you mentioned, in the very beginning I told you, fungal balls seen on X-ray, they develop in the pre-existing cavity like tuberculosis, and that can lead to massive hemoptysis. Why? It can invade the blood vessel. Now it is important. Patient has tuberculosis. He was treated. He became all right. He again come back to you with hemoptysis. Well, this can be due to reactivation of tuberculosis. But this can be due to aspergilloma also. Okay. And one more reason why hemoptysis can occur in a treated case, in this patient may even could have developed bronchiectasis. Why? Why patient develop more bronchiectasis in tuberculosis as compared to bacterial pneumonia? Because in TB, resolution occurs with fibrosis. Okay, so fibrosis can develop bronchiectasis, which can be a cause of hemoptysis. So in a treated case of TB, it could be reactivation, it could be aspergilloma, or it could have been bronchiectasis. All can lead to hemoptysis. So all hemoptysis in a old TB case is not due to reactivation. It needs a careful evaluation, of course. Aspergilloma is the one which we look like this. Look into this. Aspergilloma is there. And classically, you always get air in the balls. That is the one which really indicates that we are dealing with aspergilloma. You can see, oh, lovely picture of a aspergilloma in a big cavity in CT scan. Clue to ABPA. Asthma patient, yes. In a routine asthma patient, usually is a dry cough, but here we are getting recurrent episode of brown flake sputum. So if asthma patient with brown sputum, you are dealing with ABPA. Routine allergic cases of asthma, this is not a finding. Transient infiltrate on chest X-ray is the finding which I mentioned in the previous slides that patient can have, and that's the one which mimics like Wegener's also. Now, what are the criteria to diagnose a case of ABPA? There are 7 criteria. Episodic bronchial obstruction. that is asthma. Peripheral eosinophilia, positive immediate skin reaction to aspergillus, positive precipitant test to aspergillus, raised IgE level, history of transient or fixed lung infiltrate, proximal bronchiectasis. This is how we diagnose a case of. There are important criteria by which we really think about that we are dealing with ABPA. Supportive criteria are brown plug flex in sputum and late skin test to Arthus skin test. They are all supportive criteria. Investigation, you get transient segmental collapse can be there. There can be transient consolidation can be there, or so-called fleeting opacities. You can see here also. Proximal bronchiectasis is one of the most important feature. Here we have done the bronchogram, and you can see this is the classical finding of proximal bronchiectasis. Remember, this we have done on bronchogram. Okay. Now, aspergillus in sputum. Positive aspergillus skin test. Aspergillus specific radioallergosorbent test. Positive serum precipitin and raised IgE. In fact, they are all tests which are also the part of diagnostic criteria. So just to elaborate, to complete the list, that we all do this, but everything was there in the diagnostic criteria of ABPA. How to treat? Very, very important is patient has got bronchoconstriction pneumonia, asthma. They respond to oral prednisolone. Inhaled steroids are not effective. This is one of the most important thing that will give a clue. Patient has come with severe asthma, and usually in the emergency ward, they give this thing bronchodilator by the nebulization, or they can give steroid by nebulization in severe asthma. You are giving steroids by nebulization, no response. No response to steroid, but allergic asthma patient, they do respond very well to inhaled steroid. But here they are not responsive to inhaled steroid, they are responsive to oral prednisolone. Bronchodilator we gave like beta-2 agonist, like salbutamol. We can give itraconazole orally for recurrent episodes where we are getting brown flags also. Then we have to give this anti-fungal drug. Voriconazole is for acute invasive aspergillosis. We give voriconazole. A quick recap of the last minute revision point. Type 1 and type 3 hypersensitivity reaction, very frequently asked question in exam. Proximal bronchiectasis, these two are the most important point, don't forget. Brown flex sputum and transient infiltrate on chest x-ray. Bronchial asthma, but it does not respond to inhaled steroid. Asthma patient not responding to inhaled steroid, it is ABPA, golden line to remember. Asthma patient not responding to inhaled steroid is ABP. It's asthma patient not responding to inhaled steroid is ABP. So otherwise we give bronchodilator like salbutamol. We also give itraconazole. For invasive type we give voriconazole. Thank you very much. God bless all of you.